Good morning, everyone. My name is Benicia, and I'm here on behalf of the Urban Alliance on Race Relations. And just to kick off our event, I'd like to start with a land acknowledgement. So we acknowledge the sacred land on which the University Health Network operates. For thousands of years, it has been and continues to be the traditional territory of the Huron-Wendat, the Haudenosaunee, and most recently, the Mississaugas of the Credit River, amongst many other unnamed and under-recognized Indigenous communities. This territory was the subject of the Dish with One Spoon Wampum Belt Covenant, an agreement between the Haudenosaunee Confederacy and the Confederacy of the Ojibwe and allied nations to peacefully share and care for the resources around the Great Lakes. We recognize this agreement as not a thing of the past, but a continued promise into the present that we must be cognizant of. We have to share the responsibility of ensuring the dish is never empty, which includes not only taking care of the land and the creatures we share it with, but also the people and relationships that we should strive towards. Importantly, there are no knives at this table, representing that we must keep peace. With this acknowledgement, we must also be reflexive in recognizing and taking responsibility for our role as settlers in historically and contemporarily continuing to shape instability on these lands. Named after the fishing wires used, Tekaranto, a Mohawk word meaning the place in the water where the trees are standing, is where we are gathered today. This meeting place is still home to many Indigenous peoples across Turtle Island, and we are grateful to have the opportunity to work and learn on this territory. We also recognize the significant amount of privilege that we have been awarded and the cost that has been incurred by Indigenous communities at our benefit. Recognizing the violence that has been perpetrated through the health and medical field towards First Nation, Métis, and Inuit communities, as well as displaced people who were brought onto these lands and helped to develop this land, not by choice, but through violent force, through transatlantic slave trade. We hope this event continues the important conversation around decolonizing and creating more accessible spaces to Black, Indigenous, and racialized folk within our health and medical sector.
Welcome to the inaugural session on the UHN's, and we're hoping it will be quarterly anti-racism dialogue, brought to you by UHN's Anti-Racism Advisory in partnership with Urban Alliance on Race Relations. Hello, my name is Jacqueline Silvera, Diversity and Mediation at UHN. Thank you for joining us. Today's program, titled Racism, Anti-Racism, Racial Equity, Perspectives on Health, Education, Patient Empowerment, Innovation, and Accountability. The agenda in front of you includes opening remarks. That will be with Andrew Boozary, Executive Director, Social Medicine. Lively dialogue with Dr. Alisha Liggett and Antu Hossain, both renowned practitioners engaged in advancing anti-racism and decolonization strategies in their respective practices, and closing remarks by Sheila O'Brien. As we explore the reckoning of our histories and the living experiences of all forms of racism, we ask that we treat this session as an affirming space, where it is safe to ask questions and share different perspectives, and hold an understanding that dissenting opinions that does not cause harm are welcome. If you have any questions, please put them directly in the chat box and we will do our best to answer. This session will be recorded and posted within 48 hours of today's session. The learning objectives of today. You see them in the screen in front of you, and I'm going to go over them. Generate an understanding in the ways that racism is an oppressive system that harms health for Black women and women of color in reproductive health disparities. Identify health education and patient empowerment strategies for health providers to actively disrupt racism and colonialism. And lastly, explore best practices to advance collaboration, engagement, and partnership with communities served. As we move on, it is my utmost pleasure to introduce Andrew Boozary, Executive Director, Social Medicine, and member of the Anti-Racism Advisory at UHN, who will provide opening remarks. Over to you, Andrew.
Hi, Jackie. Thank you so much for inviting me and having the privilege to be able to provide just some, as asked, some reflections as to why I'm here and sort of my own personal take on the work and also just more broadly. And I just came from a vaccine clinic with our collaborative teams with community at a shelter for refugee populations, and asked to reflect on systemic racism. You know, I was thinking about it today that there was a woman who has my mother's name, and I think in terms of the question that I have about connection to the work and where it has started, I do go back to my mother and think of her as a woman of color. Her experience actually of her first birth and delivery of myself here in Toronto, and the care that she received and being dismissed throughout the delivery, resulting in a pulmonary embolism, and by the grace of God of being able to survive, but knowing just how much this is happening in our systems about especially women of color, Black women, Indigenous women, and the care that they receive and the systemic racism within our healthcare system. And obviously it's been something that, you know, in terms of our journey through social housing to the work that we're seeing now play out in COVID, in this pandemic, about how disproportionately impacted people of color, communities of color, Black and Indigenous communities have been, of the latest data indicating steadily throughout that it's 80% of cases, and how disproportionate the hurt and suffering has been. And really grateful for the work that the UHN Anti-Black Racism, Anti-Racism Committee and Urban Alliance have been undertaking, and to be a part of that. And my view on this is that we will not see the delivery of social medicine or of improvements in the social determinants of health if we are not an anti-racist organization, if we're not an anti-racist healthcare network. And really that those are the commitments that we need to make, that we need to see the healthcare system start to see take hold. We have lost far too many lives. We have seen far too many challenges and barriers that we have imposed on people as a healthcare system and outside our system. And really my hope is that we can see, as you mentioned, that this is quarterly, but really, Jackie, in huge gratitude and indebted to your leadership over many, many years of how we can start to see more collaboration take place, more of the sort of partnerships that need to happen, like is being presented today, to ensure that not only if UHN wants to be a leader, that has to be a leader within the work of anti-racism, but hopefully we can see this move and take shape across our healthcare system writ large. So my thank you and gratitude for the invitation to be a part of this work, and looking forward to the other presenters and looking forward to continuing in this work together. So thank you so much.
Thank you, Andrew. Important, meaningful, significant language. And I ask that we all think about the mechanisms of racism: interpersonal, internal, and institutional. So throughout our conversation, we're going to be thinking about those streams of racism and how they operate. As we start the question discussion section in a few moments, I would like to introduce Dr. Alisha Liggett, MD, known as Dr. Alisha, and also El Doctora, which I'm hoping Dr. Alisha will share with us. Dr. Alisha has a clinical practice based in New York City and is the founder of Empower Her Health. We are also going to hear from Antu Hossain, Masters in Public Health, Global Health Practitioner, and the recipient of the Social Impact and Public Choice Awards at Corporathon, which is the largest innovation challenge in Canada. As we begin the conversation, I invite Dr. Alisha and Antu Hossain to share a few moments about their journey to their current practice, and then we will begin the questions. So, Dr. Alisha, over to you.
Thank you so much, Jacqueline, for introducing me, and welcome everyone. Thank you so much for attending. So La Doctora is it's basically a nickname that I've received from my patients because I speak Spanish fluently, and it's always a mystery how I became to speak Spanish so fluently. So this is something that they always call me La Doctora when they're referring to me. So that's kind of where that came from. And I currently am a family practice doctor. I practice full-time clinical medicine in the Bronx, which is a primarily Spanish-speaking borough of New York City. And the way I came into this work was very actually unintended. After the birth of my firstborn son, I didn't have the best experience birthing as a Black birthing person in New York City. There were a lot of issues, both with the way that I was treated, with the management of my delivery, and also with the development of severe preeclampsia, which nearly claimed my life. And this experience was extremely traumatic for me, but it wasn't really until I came back from maternity leave and I started to kind of become acutely aware of the stories that were being told to me from my patients. You ever kind of get that sense that sometimes when you have a very personal experience that's kind of soul shattering, that then when you hear those experiences again, it kind of allows you to relive that and you're more acutely aware? That's kind of the experience I had. And what I realized was happening is that many of my young reproductive age patients of color would explain to me these instances of poor treatment, of mistrust, of feeling as though they were devalued and dehumanized in their body as they interacted with healthcare. Many of these instances, these episodes were centered around their reproductive health, so around birthing of their children, or even around routine gynecological examinations that they would have at the doctor. So that really kind of got me to thinking like, wow, there's so many women who are experiencing that. I wonder if this is something that's more of a widespread problem. So as I kind of started to investigate more, it's kind of speaking to more family friends, I really realized that this issue of implicit bias, and systemic racism, and poor treatment is something that's widespread. It's something that I call the silent epidemic, where it seems that every woman has a story, but nobody is actually coming forward to tell those stories. And so for me, it was just very important, given that I had been a doctor and both a patient, and really able to kind of see the nuances of both sides of the issue, that I really kind of used my voice to speak up and speak out about reproductive health disparities, about implicit bias, systemic racism, but also empowering patients, providing the tools and the skills to be able to navigate healthcare in a safe manner as well.
Thank you, Dr. Alisha. Antu, are you available? Can you hear us?
Yes, I can. Hello, everyone. Thank you, everyone here, for being with us today. I want to acknowledge the very difficult time of the third wave that we are experiencing, and my deepest gratitude to all of the UHN workers, frontline workers, for doing the most to keep us safe. So I want to also importantly frame my position and lens through which I navigate my worldview. I'm a settler on Treaty 13, a diaspora immigrant by way of Bangladesh. That actually also had the United States somewhere in there. So Dr. Alisha, I spent quite some time living in Brooklyn, so not too far away from you. And that is also, part of me being a cisgendered woman with pronouns she and her. my experiences through the systems of immigration, racialization, and class warfare have really shaped who I am today. Watching my immigrant parents make their life in the United States with not much social capital, and what that leads to is, of course, major issues in health and health disparities. We all know about the healthy immigrant effect, knowing that immigrants come to Western countries rather healthy, and then after the ongoing stressors of precarious work, just not having paid sick days, for instance, can really lead to detrimental long-term impacts. So seeing my dad, for instance, develop diabetes at a rather early stage, these are things I've seen be pathologized for South Asian communities, that maybe it's our food or our culture. But in fact, we really need to consider, I think, the environment and the built environment. So at a rather young age, due to immigration and also feeling the brunt of Islamophobia, I was always deeply concerned by how so much can change for one person just based on their identity alone, and how that actually leads to wealth. For instance, I think health is wealth, and I saw many of my communities suffer in that instance. And one of the many ways that I feel really privileged is that I don't know if I should have been here. I feel like I won the lottery of life. When I think about my dad being the one of 8 brothers who got the chance to study and get a visa, come to the US, then Canada, these are all trickle effects that lead me to the privilege I have today. But when I think about my sisters, who are my first cousins, living in Bangladesh, in the rural village where access to healthcare is still a huge inequity. Gender equity issues are very rampant. So many of that is really what propelled me to wonder, how can you make the most of your lottery of life, if you got the chance and the privilege to do that? And so that really started me in working at the University Health Network at Toronto Western Hospital, volunteering in the emergency room, triaging people and supporting the nurses. And really, that's kind of where it all began. So yeah, I'll leave it there.
Thank you, Antu. Thank you, Dr. Alisha. The healthy immigrant effect, social determinants of health, racial disparity, discrimination amidst COVID makes the next part of this discussion all the more significant and important. And everyone get comfortable because we are now going to have some conversation and dialogue. So remember, any questions, pop them in the chat. We will try to get to them. No question is too far-fetched. Everything is welcome. So as we begin, how would you define health equity? So just from a broad perspective.
Yes. So health equity, which is different from health equality, I should say, is really when health resources are allocated in such a manner that every single individual has the best possible outcomes. So it's really based on need. And when I say this because not everyone is at the same starting point. Not everyone is starting with the same level of health status. And so for that reason, there are some individuals who are going to need more resources than others, whether it be going to the doctor more frequently, whether it be, insurance, whether it be, social help with psychosocial issues, mental health issues. If they're living with a chronic disease, those are individuals that are obviously going to require more health resources than someone who's young, who's healthy, who has no medical issues, who's fully able-bodied. So health equity really kind of takes into consideration the need of the individual and ensuring that they have what they need from a health perspective to really get to a level of health that is really that's really important to have a good quality of life. Health equality, on the other hand, really suggests that every individual receives equal resources. And, you know, in a society in both Canada and in the United States where health resources are really finite, where, you know, our governments are constantly scrambling to try to scrape together some pennies to kind of throw more money toward the healthcare system, we have to be very smart about how resources are allocated such that the highest need populations really do get the resources that are needed. And I think in the case, particularly in the United States, that's really the opposite, where it's the most resource-rich hospitals, it's the most resource-rich communities that really hog their lion's share of the healthcare resources, leaving behind many of the vulnerable, disenfranchised populations that we see in some of the other poorer communities. Health equity also incorporates social determinants of health. And social determinants of health are really those factors that provide a blueprint for each of our individual health profiles. So that includes our housing status, whether we live in a private home or an apartment, congregate housing, whether we're incarcerated, whether we live in a multi-generational household, for where we live in terms of our neighborhood. Is our neighborhood situated in a place where there is healthy food access that's not in a food desert? Is our neighborhood situated in a place that's near a heavily polluted an environmental, for example, an industrial waste complex, or some sort of heavily polluting factor that could impact the quality of air, the water where you live? Do you have access to clean water? Do you have access to parks, affordable childcare, education? If you have health insurance, these are all things that we consider social determinants of health that really determine your level of access to a healthy life. So health equity really encompasses that. And I think the last part of this that's super important is the structural racism piece, which health equity also takes into consideration. So in addition to the factors of social determinants of health, health equity also looks at intersectionality, or the experience that each individual person has in their body. And that's really reflected in their upbringing. It's reflected in their culture, in their race and ethnicity, and really in their experience and their ability to articulate how it is that they experience health in their bodies, right? And that could be different for every person. Even people from the same racial and ethnic group, from the same neighborhood, even in the same family, they may perceive their experience in health to be completely different. So health equity really takes into consideration all of those factors.
I think, Dr. Alisha, you put it so beautifully that really what I would add on from my personal understanding of health equity is it's about fairness. It's about social justice, and it's about meeting people where they're at and ensuring, at least in Canada, that we're looking at health equity from an access perspective as well as from an outcome perspective. Are we effectively intervening in the ways which I would hope are community-led and community-driven to support what those needs of the very community are? And I also really appreciate that now, you know, from the medical and public health curriculum, we've adopted the SDOH language, social determinants of health, to the point where it's become quite normalized. You know, I thought when I was studying public health that, oh my God, it's this framework that only the nerds know about. But no, I think to see it become so accessible is great. It allows us to have a jumping point, I think, to actually assess, okay, what is happening here when it comes to equitable practice? What are the factors? However, you know, I would just say that I think beyond the theoretical concept of identifying the factors, I think we can pat ourselves on the back for coming to a consensus around language. But I would fear, and I am starting to see, the highly politicized nature of SDOH and health equity. You know, with the EDI movement, the Equity Diversity Initiative movement, which I really hope is not just a movement, but, you know, is here to stay at the core of our society. I think we see often institutions use these terms in statements, in reports. And I think what I would like to really question for all of us here on the call is, how do we get past the language and patting ourselves on the back for now all speaking the same language, but moving to understand what are the barriers within these institutions that are leading to these social determinants of health as being leading to poor health outcomes. It is not race that affects poor health. It is racism. It is not age that affects poor health. It is ageism. And now what are the roles that institutions are playing to either perpetuate those barriers or dismantle them? So those are my few add-ons to Dr. Alisha's most beautiful reflection on health equity.
Unmuted. So thank you. As I listen to both of you, the phrase that we have been using at UHN is substance over symbolism. You know, right now in communities, there's a lot of symbolic work that's taking place, and this is cross jurisdictions. So if we agree that that is, you know, where we're all intending to go, very substantial work, I would put to you, when we speak about disproportionate experiences, as you have both alluded to, of health across racialized women, non-binary, trans folk, persons with disability, there's this compounding form, marginalization, big word, the experience of marginalization. How have you seen this in your work? Dr. Alisha?
Okay. I wasn't sure if you wanted me to go ahead and go first. Okay, so in speaking, so just to clarify the question, in terms of speaking around trans and non-binary individuals, yes? Okay, yes. Absolutely. Yeah, I mean, I have absolutely seen in my practice that, you know, how this concept of intersectionality, which I mentioned before, really plays out very specifically for this population. Medical establishments have really historically considered non-binary folks, in particular those individuals who identify as transgender, as really having a mental illness. And it really wasn't until the year 2013 that this term gender identity disorder, which was listed in the DSM, which is a manual that's really used to diagnose psychiatric and psychological disorders, had really been changed. And with that, this term, gender identity disorder, it was really implied that someone's gender identity was really an issue, was mental illness. So it really wasn't until that time that it was really changed to gender dysphoria to really reflect that this is not a medical issue. This is a gender identity. This is someone's experience in their body that should not be pathologized. One of the other issues that I've seen that's been very, very stark as it relates to this population is also insurance discrimination. For many of my patients that come to me that are seeking procedures to validate who they are in their bodies, so that they're, you know, the way that they look really aligns with who that they feel they are. Many times this requires them to have surgeries or procedures so that they can kind of reach that goal. But what is happening is many insurance companies are either denying coverage for these procedures, or they're requiring that these patients jump through hoops, such that they have to get letters from psychiatrists or psychologists saying they're of sound mind, almost as if, you know, going back to this very archaic implication that there's some sort of mental issue or mental problem that they have. So I've seen that quite frequently in my practice, and it's something that, for me, I've really had to advocate for patients in this manner so that they can really get the care that they need. Also, with lack of resources, in some cases, individuals, particularly those individuals who identify as transgender, in terms of the social determinants of health that comes to a head, you know, issues of housing, issues of safety, which all require a multidisciplinary team to really, really assess and to address those issues and provide support. And sometimes those, resources are not available. For example, social workers who kind of really uniquely understand this experience or who've worked with patients like this in the past. or providing housing options for these individuals such that they feel safe where they'll be staying and won't feel as if they're going to be bullied or going to be attacked because of their gender identity. So those are also issues. And just the issue of discrimination, being misgendered when you come into the office, being treated poorly because of your gender identity, being the victim of very circumspect stares from healthcare providers and healthcare staff, and even kind of being on the receiving end of very probing, inappropriate questions about your sexuality, and about the decisions that you make about your body that really leave the person feeling as if they've been dehumanized and discriminated against. And with that, this gender dysphoria that many of these individuals experience really kind of translates to higher levels of depression, anxiety, mental illness that all kind of boil down to this experience that really is very unique to this population. So, in my work, I've seen a lot of this. I've seen a lot of young people who literally have left their homes because of social isolation, because of the fear of violence, who've left even the state. I have patients who've come up to New York State, which is a state that's very liberal, has a lot of resources for individuals who across the gender spectrum, for housing, for health insurance, providers who are comfortable seeing these patients and who are very culturally responsive to their needs. People who literally will leave their homes, leave their families just to obtain quality care, to be able to obtain gender-affirming hormone care in the case of our transgender women and men. So this issue, is extremely important in terms of recognizing the unique experience of these patients.
I really, really appreciate that perspective, Dr. Alisha. Some of the things that I want to acknowledge as well in the vein of transgender and gender non-binary and gender non-conforming folks is that transgender visibility. You get. And this to systems and structures which exclude trans folks at the most margins of society. I particularly want to note that being a trans woman of color, and even more so trans Black women, are the ways we see intersecting identities leading to the most vulnerable who feel the brunt of medical violence. When it comes to engaging, to breaking down these binary, heteronormative, and patriarchal lens and the way in which the world works, I think we need to center the experiences of trans folks and gender non-conforming people. I'm seeing a question here, but I will hold that off. In non-conforming peoples to lead in how systems and structures can be designed, and that will benefit them and an equitable society. So I know these conversations can be difficult. I'm actively unlearning all the time, and I think the biggest part is working through our discomfort. It's the first step to finding some clarity to what is effectively us trying to reimagine a world that is different from the one we already live in. And I think we need to believe people. We need to believe trans folks and gender non-conforming folks when they say this is my pain and this is my experience. We shouldn't go out looking for more and more data to validate it and validate their experience. So I do believe we each play and benefit from these systems of domination. We do. And I think the biggest question we can ask ourselves taking away from today is, what is my role implicit within these structures? And what am I going to do to actively mitigate the harm that I could cause because I know I'm benefiting from this structure? I know that I am a cisgendered woman and that is to my benefit. So I did want to share some insights on a project that I've been working on that relates more to how I've seen the compounding effects of marginalization. So in one of the projects, I've come across a significant gap in understanding what makes a healthcare system inclusive for diverse peoples and diverse groups, particularly as it relates to navigating sexual health and wellness. A very vulnerable space, you know, a very vulnerable space. But, you know, I think we haven't really asked people themselves what would make a healthcare space inviting, warm, what would allow that healthcare experience to, you know, be positive for you. I do think as we, you know, have started talking more and more to various peoples of various communities in the research phase that we're in, what we often found is that the barriers to entry to sexual health and wellness, particularly for racialized women, as that's the majority of people I've talked to, is significant. When we ask people, what does sexual health and wellness look like for you? I think it's almost like, for many people, the first time they heard this question, and also like, have you accessed any sexual health and wellness services? Often we're hearing no, unless like, you know, it's a severe thing like a urinary tract infection or something like that. But really, for a simple question, a simple question of, you know, consent, healthy relationships, navigating sexual health and wellness for the holistic experience, people are not actually going into the healthcare system. Why? Some of the things we've heard are confusion, uncertainty of entering the healthcare system, let alone the fear and mistrust. Health literacy being a huge gap. And when I say health literacy, I mean, where is the education piece around how the sexual health wellness experience will look like for me and my identity? Where do I find this information beyond just the biomedical? And how can I relate to that experience of somebody else, let's say, before entering the healthcare system, so that I know that I can trust it? We know that there is intergenerational trauma within racialized and marginalized communities, particularly I would note Indigenous communities as well. So there is a lot to unpack, and unless we really validate experience and what someone's experience would mean to dictate a better health outcome, I think, you know, there's going to be many places that we just haven't addressed yet. So this is kind of where, you know, I've sat with seeing and hearing about marginalization of experiences. I think you're on mute, Jackie.
There we go, got you now.
Okay. Okay, thank you. Couldn't get it unstuck. So thank you. There are a few questions in the chat, and I was wondering if we could just pause and look at those. So the first question is, what is diaspora? So Antu, can you take that one?
Absolutely, and thank you for that question. A diaspora is really many of the immigrant, third culture, you know, it's really that catch-all term for those who are settlers in Canada, for instance, like myself. So it's kind of encompassing my immigrant identity, but also the fact that I relate to multiple experiences in terms of culture and positionality. So I'm Bangladeshi Canadian. My diaspora identity is shaped by being Bangladeshi Canadian. So I hope that answers that.
Thank you. Dr. Alisha, did you have anything to add?
Yes, I thank you for that, Antu. I just wanted to add quickly also that even for individuals that might be, you know, second or third generation in their country, away from the home country, that in many cases too, they consider themselves part of a diaspora. So I myself identify as African American, and although I don't have any direct family members that live on the continent of Africa, I still very much identify as being part of the African diaspora. So it can kind of go the other way as well for individuals who have a direct connection to their home country or homeland, and others who may have that connection in spirit.
Thank you. So there's a question specifically for you, Dr. Alisha. And the question is, there are inequities for women in medicine. Specifically, many women feel that they must delay parenthood because it might impact their career advancement in practice. Dr. Alisha, if you feel comfortable, would you mind sharing your experience and thoughts on how to make more equitable programs that support women?
Absolutely, absolutely. I mean, as someone who myself delayed childbirthing until the latter half of my 30s, this is a very, very important issue, especially as it relates to supporting women in the workforce. I think number one, there definitely needs to be opportunities for women to have paid family leave. I mean, just at a very basic level, when women do, decide to start a family, it's important that there's those safety nets in place that allow women to continue to thrive in their families, support their families while they're out caring for their children and bonding with their children. So that's number one. And Canada, I mean, I'm not aware if Canada has such policies. I'm sure you all do. In the United States, this is something that is a relatively new concept. During my first child, when I was on maternity leave, I did not have the privilege of having paid maternity leave, so I was literally out with no pay for 4 months, and that is incredibly anxiety provoking when you have to still support your family and pay your bills, and it just placed a huge financial strain on the family. So that's number one. Is like support women when they're out. We are just as valuable in the workplace. And it's important that our employers do support us in terms of being there for our families. Women shouldn't really have to choose. I think there's this also this misconception that you have to either have a career or have a family. And I think, as part of industrialized societies, it's important that we prioritize both, that women can both be an active part of the workforce, contribute our ideas, our genius to the advancement of our society, as well as those same skills and talents to our families. So that would be number one. Number two, it would be super important for women to have a seat at the table. And not just, women really of diverse perspectives too. Women who are of diverse orientations, sexual orientations, religions, life experiences. These things are all super important in terms of bringing diversity of thought to organizations as well. So really providing women with opportunities for career advancement and a seat at the table in leadership. That's also very important. Those are just some of the ways, but I think also us as women in many cases have internalized that we do have to make a choice. And in some cases, it's up to us to also be empowered and assertive such that we are able to really kind of assert what it is that we need from our employers as well.
Thank you. I would like to pose a question to Antu. And the question is, your work incorporates evidence-based research. Can you speak to research strategies and how that informs your work, especially in light with the comments you had previously made?
Absolutely, and thank you for that question. And Dr. Alisha, I could not agree more on the empowering strategies that you mentioned for women in the workplace. I think with respect to what I want to share is that I do want to centralize in my work the legitimacy and value of experiential knowledge. So I mentioned it a little bit earlier, but what I really mean is, what are those granular, nuanced, living day-to-day experiences and realities of people, and how are we particularly validating them or invalidating them, and therefore maybe dispossessing some communities in the process and not validating their experiences in the process, or in fact offering them that space on the other end, which is where I think we should be aiming towards, to decolonize our knowledge of what we believe is fact and truth, and working in quite a biomedical field, this is an ongoing struggle. We do know we have standards that have been created for what is considered to be rigorous pieces of knowledge, scientific, post-positivism oriented. However, I would say that my research and work has supported valuing the localization of knowledge, particularly working in international development. We see huge disparities between who gets to be funded to do the work of health programming on the ground. Is that led by communities? Is it led by their community valuable knowledge? Are we actually taking a step back and wondering, is it Western Eurocentric views of valid knowledge that I believe in versus what this person here, who is an expert on their experience, is telling me about their community? So I think in some of those ways, some strategies that I've tried to incorporate and advocate for is peer ethnography. Peer ethnography being the ability for people to really not only look at a problem, but also how the problem and situation exists within the larger context in their environment. And it is a much more intensive research process, don't get me wrong. However, I do believe that when we train those who are from the community to effectively do the research design, to ask the questions with their own peers or their own community members, you're going to get a more nuanced and rich perspective than you would if you didn't relate to them immediately. And so I think that also really is starting to feed in to the idea that even here in Canada, we need to be constantly advocating for who is at the table when we decide how programs are designed, when we decide which research studies and research questions, in fact, are funded. Is it the very same communities that will be affected by that research? And what are the processes we will set in place so that they own that research as those communities? Because, or else, over-researching is something we are often falling into a trap of. And this is where, I would hope that strategies like peer-to-peer training, building and leading with grassroots organizations, like I see here today, with Urban Alliance for Race Relations, who has such an incredible reach within the community, partnering here with UHN, we are starting to see people take on mutual strengths and equitable partnerships. And I would say that's actually a key way to start building research strategies. So yeah, that's where I would.
Thank you, Antu. There are so many questions that are popping up, and there is a question that overlaps with what you have just shared. And the question is, as with any health issue, there's a lot of possible spaces to take action here, from assisting patients with health literacy, environmental safety, etc., to changing doctors' practice perspectives to system-level interventions. Do you have any thoughts on whether any specific domain is better or more impactful for intervention? So it seems to me as if you really, have responded to that in some way. Is there anything that you would like to add?
I would say the best people to ask for where we should start is the very people we're trying to understand and to help alleviate their concerns. You will hear from them. They will tell you what they want to see happen. Those community needs assessments are very valuable. They're not just, the baseline that we need to do. When done correctly, you can actually see where the priorities are with those very communities. I think, we are seeing a lot, especially in healthcare technology, a lot of front door, quote unquote, ways to access health and healthcare. So health literacy is still a very significant gap. And I am seeing that in my work as well. So that is one method, but I also think there is a deeper, the harder stuff as well, like what are the systems and structures in place, and how are those logistics happening in the back end within the healthcare system that efficiently and effectively get someone to access a program or access treatment. Those also have to be in tandem addressed. But I do want to say that a place that I have come from is health literacy and trying to close that gap. I don't think I would be the only person to be the expert here, though. I would always look to the community as to where their needs are most.
Thank you. Well, it sounds to me as if there's a part 2 of this conversation to come. Thank you. There are questions that are popping up in many areas. Because we are coming to the close of this talk, what I would like to ask both of you to do, if there's any possibility of commenting on the progress that you have seen or how you have been evaluating the progress that you have seen. Can we do that in 30 seconds or less?
I'll try to wait. Yeah, I feel like there has been some progress. There's definitely been a heightened awareness around the importance of structural racism, addressing it and really rooting it out in all of our societal systems, not just in healthcare, which has been amazing. A lot of that has really been a huge push from the grassroots level with massive protests and street movements, for social justice, which has been amazing. Other things that we've seen, which has kind of really been illuminated by the racial and ethnic disparities we've seen in death and hospitalization with COVID-19, is really that we have a lot of gaps in data collection, right? So they say if you don't measure it, then it doesn't exist. So one of the things I think that's super important is really, how we collect data. And I think there have been improvements in conversations and awareness around the deficits and corrections being made, particularly at our government level. Accountability structures, those things are currently being built. Curriculums are being redefined, particularly in medical schools across the United States, where students are demanding social justice curriculums, understanding of the very racist history of medicine and what they can do to help to root out implicit bias and systemic racism and perpetuating that. So I see that there are, definitely some moves forward, also just on the governmental level in terms of really trying to change the systems and structures that provide access and allocation of resources to individuals as well to make their profiles better. So there is some movement, which is really, really great. I guess that's my 30 seconds.
and here we have another 30-second request. And this is, and I mean, please, both of you, comment on the experience of healthcare workers and how we can recognize when healthcare is going down and how we intervene safely. So in the midst of COVID, this is top and foremost of everyone's mind. Any thoughts?
Yes.
And this connects to racism, of course.
Yes. So healthcare worker burnout is a huge problem. It has been before COVID, but again, this kind of COVID, really just the stress that it's placed on the healthcare system and really exacerbated disparities in resources and things like that has made it much more difficult for healthcare workers to do their jobs. Issues with just having safety equipment, PPE, to be able to protect yourself and your families, long hours, shifts, very, very sick patients, and also just the emotional toll that it takes to be a caregiver, especially in instances where there's, so many people who are dying, and often without the support of their family. It's very important that hospital systems and clinics really support healthcare workers in a way that's tangible. So it's wonderful that people are, thanking healthcare workers and clapping every night out their windows in New York City, which is what they do. People kind of hang out of the window, clap every night at 7 o'clock to thank healthcare workers, which is amazing. However, it would be better if healthcare workers were actual, for example, offered psychological support for the trauma, the work-mediated trauma that they're experiencing, or hazard pay, for example, for having to, pay for higher rates for childcare, other services, so that their families are well taken care of. So those are all things that I think are super important in terms of valuing healthcare workers as well.
Thank you. I do see more questions, and I think what we will try to do for those of you that do have more questions, we'll try to respond to them, and when the recorded session goes out, we will attempt to have some responses there for you. We are coming to the close of our session, and I wanted to invite Sheila O'Brien, who will be providing some closing remarks.
Thank you, Jackie. First of all, thank you very much for everybody who's been involved in this important conversation. Thank you for all the participants, and thank you especially to Urban Alliance, our partners today. On behalf of the Executive Leadership Forum and UHN's Board of Trustees, I want to thank sincerely Jackie Silvera and the Anti-Racism and Anti-Black Racism Advisory Committee. These are such important things for us to be talking about and working on, and Jackie's leadership and the leadership of this group has been invaluable. We all understand healthcare as an essential service, but so too is anti-racism work, as we've heard today. Essential to us as individuals, as care providers, and essential to the values of Team UHN. We are by no means a perfect organization. We're trying, but we're not there yet. We've made mistakes in the past. We'll make mistakes even now. But what we will not do is ignore the harm caused by indifference, ignorance, and in some very sad cases, outright acts of aggression. Our commitment is to cultivate a safe, inclusive environment for our staff, our patients, and each other. But as we all know, words are just words. Actions are what matters here. We're so proud of the anti-racism and anti-Black racism policy Jackie has spearheaded and shepherded through its unveiling in February. This is new for us. The policy is new, but the work isn't new. Jackie and her team have been doing it for a very long time, and thank you for that. Many years and lots of real life experiences went into the making of this policy. It's our guiding document. But how we make it real and impactful for every member of Team UHN will be the test. As a new Executive VP of People, Culture and Community, I am so excited to partner with you and be involved in trying to walk the walk here. Thank you for keeping the faith and for continuing on this journey with us. And on that note, it's more important than fitting that I leave the last word to Jackie Silvera. Thank you, Jackie.
Thank you. So here's my 30 seconds. Look, folks, as we ready for wave 3 in Toronto, Ontario, or Brooklyn, New York, the commonality that we all are experiencing is fatigue, uncertainty, anxiety, combined with recent events, violence, hate, discrimination, and there's this exhausted list that I could go through. The one comment that I want to share to all of you today, those of you at Team UHN, you're not alone. If you're stressed, if you need support, reach out to your manager. The peer lines are working. If you're experiencing discrimination at UHN, contact us, reach out to the resources that you see online. We've updated the anti-Asian racism resources, all of you, for all of us. Most important, don't go it alone. For those of us who are working over the long weekend, we thank you for your service. If you are not working, take the time, enjoy the long weekend, and indulge a little or a lot. For the many faith-based communities, this is a time for deep reflection, contemplation, and renewal, something that we can all benefit from. We ask, no matter what we're doing, take good care of yourself and loved ones. Thank you. See you next time on behalf of the Anti-Racism Advisory and the Executive Leadership Group at UHN. Be well, everyone.